Great. Welcome back to House Healthcare. We are happy to have Department of Mental Health back to get to the one program we couldn't get to yesterday, which are CCBHCs. Turn it over to you.
Correct, thank you. For the record, Emily Hawes, Commissioner for the Department of Mental Health.
Allison Crum, Deputy Commissioner of the Mental Health.
So yes, we are here to complete some testimony related to certified community behavioral health centers. This is not a revamp, but a way of looking at our overall system of care from a little bit of a different perspective than what we have historically. I'm gonna, while we're working on bringing up our slideshow, there it is, and there it comes. Great, cool, because I wasn't really sure how.
This the one you had yesterday. It's
The same slideshow as
Same
yesterday,
slideshow.
and we're
Thank
gonna be
you.
at slide 24.
All right.
If you want to
Excellent.
go over to that, yeah,
Yeah.
great. And so certified community mental health or behavioral health clinics are clinics that encompass both services for folks experiencing mental illness as well as substance use. And so that's a little bit different than our current designated agency system. Not all agencies deliver co-occurring care through the preferred provider system, which is the substance use system language. And so the CCBHC model really focuses on that integration as well as a more sustainably financed model of care. So some three key indicators, if you could just go back one more, is ensuring access. So to integrated evidence-based substance use disorder and mental health services, which also includes 24/7 crisis response. We've talked a little bit about mobile crisis response yesterday. So that will loop into our CCBHC work, as well as medication assisted treatment. And if folks aren't familiar with that term, it's also called MAT. And that is medication used to treat people with opioid use disorder. You have to meet, the agencies or clinics need to meet stringent criteria regarding a timeline for access of care, quality reporting, staffing and coordinating with other social service agencies, the criminal justice and educational system. And then it also allows the ability to receive flexible funding to support the real costs of expanding services to fully meet the need of care in communities. So we see this as a really wonderful opportunity to take a look at our system and develop a model that serves our communities in a more integrated way and also at the cost of delivering those services.
And there are other states doing this today, correct?
Correct. So this has been rolled out in a little bit of a tiered fashion. Folks can be a CCBHC without any interaction with the state. And there are clinics that exist nationally that don't have any connection to the state. Or the state can manage and certify clinics who meet the criteria. So several years ago, Clara Martin Center was applied for and awarded a CCBHC grant. They've been working towards these requirements for a while. In the last year, the last 2 years, multiple other agencies have also received planning grants to move in this direction. And then a year ago, the state of Vermont was awarded a planning grant to explore the potential for moving into the CCBHC system. Additionally, we have a policy academy with Vermont Care Partners that along with the National Council of Wellbeing to also take a look at what were some of the things to consider when moving in this direction and how it ultimately serves our communities better. So like I said, Clara Martin Center has the planning grant, also HCRS, Howard Center, Northeast Kingdom Human Services, and Rutland. And then, like I also said, we have a federal grant for about $1 million to continue this work.
So right there, it says $1. just for future reference.
We're not good. You can tell the math people didn't.
Easy, efficient. That's all it takes. No, we got it. Here. I don't even go to the budget. I'm just going here.
Look at my face turn red. I'm not gonna cry. I did a few years. Go ahead.
One thing I wanted to add, because I noticed it didn't call this out specifically, but it is an interesting aspect to CCBHCs. First, I want to say that not everyone in Vermont likes the term CCBHCs, and so I want to honor that and say we are looking at alternative language. Behavioral health is a national term that encompasses mental health and substance use. It's an easy term to say, some find it harmful. Yep, so we're looking at a new term. The other piece is that it's opened our eyes towards the need to coordinate for service members and veterans. There's an assumption that all veterans and service members get a lot of their healthcare through the VA, and particularly for mental health services. That's actually not the case for lots of reasons, including driving to where they are, let alone, maybe your own experience or wanting to identify that through that door. So there's a lot of need to do better coordination and to better identify and serve that culture. And so CCBHCs require that you coordinate better, that you have services that are specifically targeted for that population. So we've seen that as a need in the suicide data that we have, particularly that terrible year, 20% identified as veterans that we lost by suicide. So I just wanted to point that out.
I just want to make sure what you just said about veterans. Are you saying they only can get mental health services at the VA?
That is not true. What we found is people can sometimes assume that that's where everyone's getting their healthcare, mental health or otherwise, when actually they're coming to community mental health centers, but not necessarily identifying themselves as veterans or nobody's asking them.
Okay, all right.
So they're entitled to
Because
additional
veterans can
benefits.
go anywhere to get the service.
Correct. But we don't
So
know
no-
always where they're
no law.
going. Yeah.
Good one, too.
Another core component, in addition to the work with veterans is also incorporating those individuals with lived experience into the delivery of care. So there's a peer component to CCBHCs as well.
I just wanted to come, so go ahead. Are we still on the slide?
I haven't got to it yet.
Oh,
I
okay.
don't even have to go there yet.
Okay, when you get to that slide, I have a comment, so we'll wait.
Okay, so we'll go on to the next slide. So currently, the department is engaging in a community public input and stakeholder engagement process. And so what that currently looks like is in-person meetings. I think we had one last night down in Rutland. We also have online survey as well as remote questions to give input through the stakeholder engagement. And then we have a steering committee to help develop the model. And that just began in December.
Those are publicly notified, your community meetings?
I believe so.
So that's what I was gonna comment on. So I signed up back in March to be on like your email list.
Yeah.
And so I got a thing about it. And so then I went to your website because I thought, oh, I'm gonna grab what I can from the website and easily put it on Front Porch Forum for people.
Oh, yeah.
I couldn't find it anywhere on your website. So you just might want to check that. Thank you.
Yeah.
I really searched as much, but it could be user error. But if it wasn't easy, yeah, exactly.
We have had some other challenges accessing information on our website. So I thought it was all remedied outside of CCBHC. So let us.
And this was about a week and a half ago.
Oh, really? Okay.
So it might have been fixed by then.
There's a listserv on there as well, just to piggyback on that, that I signed up for last
Did it
summer,
come through
and I
you?
never got a notification from the listserv that there was activity happening.
Okay.
Okay, we haven't done this before, so we're
Yeah.
all learning, and I'm happy to be a guinea pig.
I think, yeah, we will look into that because there was also, I think, Front Porch Forum ads. We had a whole plan around communication out to those stakeholder engagement groups, because we want folks to
Right.
be engaged in
Yeah.
them. And I think the first one, maybe it was just Simone that attended, but it was also a snowstorm, which we thought
Right.
might have impacted
Yeah.
it. So we'll look into that further and make sure we clear up any lack of.
And if you have, Front Porch Forum, ready postings, send them because, we're happy to put them on when we post them from.
Okay, yeah, great. Let me just mark that as, let's come back to that with Alex. Thank you.
And Art, did you have a question?
Well, I don't, but I can come up with one quickly. In sitting here and thinking about this, and please don't be offended in any way, but we just, I anyway, I guess, hear about so many different agencies and things. And this is another one. And I'm trying to figure out what this does that the many, many, many other things we do don't do.
That's a really great question. And I would say what this does, it makes all of those things more comprehensive, more quality data driven. But then also a different payment model that pays for the cost for the delivery of those services.
And what is that? Oh, you're gonna go into it, or have you done it already?
I haven't done it
Oh,
yet.
okay, all right.
And we're actually, and I won't have like clear answers that says it will
Sure,
cost this
sure,
amount,
sure.
because that work is just now starting.
Yeah,
But the way the CCBHC model is designed is you can design it off of a daily rate or you can design it off of a monthly rate.
Oh.
And so our folks, our business office is working really close with the broader system. Primarily the two agencies that we've chosen to do the demonstration with, to take a look at those costs of service and then make some determinations around a daily rate or a monthly rate. And it moves you away from like a fee for service.
okay.
You know how you've talked, Art, with me about, it's so frustrating, and we all have this frustration that people aren't getting paid what the true cost is of the services they're providing. This hopefully helps us get a little bit closer. Plus, it's also, we're not creating a new organization. It is the designated agencies that we already have today. Right? Correct me if I'm wrong.
That's what I was gonna say. We're not building a new building next door to ours.
Okay, so these are the same people doing different things?
Right, so if you want to explain the difference between,
Yeah, that was exactly my point, was to say, when you think of certified behavioral community health clinics, they would be, once we have them, it's not like we would build one across from CSAP or UCS. An agency is applying to get certified as one.
Yes.
And so to get certified as one, they have to sort of make sure that they give all the services that CCBHCs require, which in this case means for some of them doing more substance use than they do now, because some of them don't. And as well as meet certain quality requirements. Those are sort of, it's coming up with a standard, different than the standard now. And then they get to apply for certification. The other thing I would just note is in applying to the state, every region that wanted to apply had to do a community needs assessment. That kind of looked at, do we need one of these in our region? Is there an NFQHC that's already meeting the need, is a question that we
Well,
ask.
that's good, because I think that's important.
Yeah.
If you're meeting the needs, we don't need someone else meeting the same needs.
Right.
Yeah, okay.
And I'd say that Rutland Mental Health Center was one of the agencies that was chosen to work with us to be a part of our demonstration application.
Of course, so.
Yeah.
and if it's, one second, Daisy, and if I can also say, Vermont Care Partners, who's in the room, we've had conversations. And they're working on a testimony for us that will show a continuum of care within, for mental health, within and substance abuse in the appropriate cases, where they're going to also bring in some of the on the ground people with these various programs we're talking about. So hopefully through that presentation, it will become more clear for all of us kind of where everything fits in the continuum of care in our mental health system.
I think that's real important.
Yeah,
Because it just feels very fragmented when we
Right.
hear it the way we do.
Yeah, and I think And I think, I think when I was here, started 8 years ago, whatever it is, I feel like it was probably more fragmented than it is now. It's probably still some fragmentation, but everyone's, coming together more and saying, what is our system of care? And there's different programs depending on where you are in that system of care, but it is a continuum. There's still gaps and there's still probably some overlap, but we're getting there. Daisy?
So I think the other thing that makes this different and I think it's really important, is it's not just the DAs, right? They have to have certain services that they're required to provide.
Okay.
And not all the DAs do provide those services. So they can have partners, and I'm sure they're going to talk about the DCOs. They can have partners that are fulfilling those services right now. So this connects people who are already providing those services. So it's not reinventing the wheel, but it's creating partnerships. It's creating a new model that will allow more people to have a higher reimbursement rate. And it's the certification isn't just for the DA, it's for, everybody participating in that model. So more providers benefit from it. And the CCBHC isn't just, four walls. It's really to incentivize care coordination and getting care in your community wherever you're at in innovative ways.
Okay.
Do you mind if I add on to that? Because you said that really well. And the great thing, one of the great things about Rutland in the application is that they currently have MOUs with other providers in the area. And so what that does is transition those MOUs into a more official requirement for the delivery of care. And that's what we want to formalize those so that it doesn't feel as fragmented, so that there is a more formal, cohesive system surrounding folks.
In community.
Yeah.
Okay.
Great. So I'm going to talk a little bit about the steering committee membership. So what you see here on this slide is a breakout of the individual who are on the stakeholder group. So folks with lived experience. Almost half of the members of the group are individuals who are folks with lived experience, individuals from the designated agencies, federally qualified health centers or FQHCs. We also have folks represented from primary care, substance use, blueprints, our Refugee New American group, legislative, criminal justice, advocacy, workforce training, and then where we didn't get folks to participate is down at the bottom around housing, homelessness, veterans, older Vermonters, youth, and employment. So this stakeholder group will be the group of folks who will really assist DMH and the state in taking a look and making some decisions or explore some decisions that will eventually go into the demonstration. Anything to add to that?
And this just kicked off in December?
Yes. And I want to say they had one meeting the other day.
Yesterday.
Yes.
They,
Yeah, Wednesday was yesterday.
and can the public attend or are they?
I don't know. I don't oversee the steering committee group, but I
There
think
were
it is
members
a public member. I think it is a public meeting. Yeah. And we should check on the list to make sure that that's being communicated out too,
Yes.
because that's different than the stakeholder engagement.
Great. Okay. Okay.
What substantive difference will it be for the person who has a substance problem? What are they gonna see different than what they see now? I don't know what you do now, I'm not doing that. I can't imagine, but I'm wondering what the difference will be today from when this is enacted.
Sure. And that's a great question because I think there is an assumption that when you walk into a designated agency, they're serving both your substance use and mental health needs. And that is sort of true and not true at the same time. So what you could what somebody may experience is you come in and let's say you have an alcohol use disorder. And the agency you were at was not prescribing medication or delivering treatment groups for an individual who has alcohol use disorder and also co-occurring symptoms of mental illness. And so the change for you would be, you would go in, you are assessed, you are determined that you would benefit from receiving services for your alcohol use disorder. You're willing to engage in those services, and you have a psychiatrist and a treatment team who is able to deliver that care. Versus where you might have to go somewhere else entirely to have a treatment provider serve an individual who has alcohol use disorder.
So today, that would be the case, you're saying?
Depending on which agency you go to.
Really?
So,
Okay.
for example, Lamoille County Mental Health is not a preferred provider, which means they are not part of the substance use preferred provider system. Now, they may deliver co-occurring care in some capacity, but if an individual needs medication or a higher level of substance use treatment, they would then likely go to the local FQHC to have that service delivery.
All right. But now it's gonna be able to be done at the same place.
It can either be done, Lamoille's a great example. It could be done perhaps at Lamoille, or a formal relationship with that FQHC could happen where that individual is not seeing two different folks, but it's
Right,
more
you
collaborative.
want, right, that's what I'm saying, when this
Potentially.
takes effect, you'll be able to go to one place and get it.
Essentially, yeah.
Thank you.
Back to the timeline. So this is back to our planning grant. So you'll see that we are coming up on the finalization of our planning grant. We're waiting for SAMHSA to release the application for us to become a demonstration state. That will be due in March. The application was supposed to be out sometime in December. So we'll see what time, but we don't anticipate much of a change with that. So right now we're doing our public engagement. We still plan on applying to be a demonstration state in March. We'll do more public engagement across the summer of 2024. And then it will come back in front of you. We'll be back in front of you all maybe next session with the potential implementation of July 2025. That is if we get chosen to be a demonstration state. If we don't, we'll reapply until we do. But they're only choosing 10 states per year.
I think I'm not understanding. There's the CCBHC planning grants.
Yes,
That's different than what you're talking about there.
it ends in March. That planning grant has got us through the selection of 2 clinics for initial certification. And it's also getting us through our public engagement model and all of the legwork it took to get to there.
But the 5 people that are listed, 5 designated agencies that they each got $1 million.
They had separate grants.
That's seperate.
Mhm.
That's what I'm confused
Yes,
about.
yeah, they had separate. Our grant was only $1.
I know.
So those, the agencies' grants are separate than ours.
Oh, so those agencies apply for them specifically on their own, and then you, as the DMH, are applying for this thing.
Yes,
For the whole state.
for the whole state, that's right.
Okay.
And if you think of future state, we're starting to bring on, as agencies are able to meet the criteria that come on CCBHCs. And so those planning grants are really helpful in supporting the work because it's very different from a quality perspective, from electronic health record requirement. The lift is quite tremendous.
So what's gonna happen if this grant doesn't come through to the 5 designated agency work?
Sure. So those 5 agencies will continue to apply for the grants that they'll apply for. Our ending of our planning grant in March will not, and will still apply to be that demonstration state. And if we don't make it, I don't know if there's other grants for us to extend that planning, but our goal is to become a demonstration state.
Okay, but that would be great. Okay, I get that.
Yeah.
But let's say we don't. I'm just saying, so then how does this ongoing work get funded?
So the agencies would continue on their track towards becoming certified. And then from my perspective, and I haven't checked this with Allison, so she may punch me in the arm and say like, that's just not right.
That would be vital.
We frown on that.
I was in the workplace.
But I think that, for the state to have a say over, certification or have an impact over that certification process and be able to help deliver it. Those planning grants are incredibly important and the demonstration statements are incredibly important. And that demonstration equates funding. So if you're not a demonstration state, you're not getting the federal funding for those.
Yeah, that's not really tracking.
Yeah.
For me right now, and I'm sure it makes sense to you.
Well, I think the planning grant's been really helpful, but also really, it's intense. I mean, that timeline was really short to try to get an application in. So we've worked with these consultants. We've really positioned ourselves differently. And from what we hear from other states, it's not only competitive, but often that you don't make it the first time you apply. And so we're looking at the reality here that in the state that we're in with the timeline that we had, it's actually quite likely we may not make it the first time. And that's not in any way slowing us down to this ultimate vision. I feel like we've really, it set us up for this year. And then that just means we have more work to do. We know what that work is.
Right.
So, we can usually find some, if we need to continue on with some consulting dollars.
Well, you'll find more money when the 1 million runs out, whenever that is. It doesn't say.
It's March.
March of 24, that's the $1 thing?
Yes,
I got a plus that. Okay, got
the
it.
pennies are gone.
Yeah. Okay, thank you.
Daisy and then Art.
I think also I would,
Did you want to tell your background on this?
CCBHCs. I was at the place that our state had some technical assistance with to explore whether, I guess it was your policy academy. You referred to it here.
National Council of Wellbeing.
Yeah, I used to work there for 7 years, 8 years. And that was during the time that the CCBHC model was being developed with SAMHSA. So I'm very familiar with it,
Which is helpful to us.
good. I hope it continues to be. I was going to say, even if the state doesn't get in this round, every organization of those 5 that got the planning grant is already benefiting from the work that they've done with their planning grant.
Correct.
So the planning grant helps them prepare to get certified and meet the requirements, which are, doing back office improvements and streamlining their workflows, yada, yada. So they're already getting people through the door faster. They're having, shorter wait times and things like that. So we are already benefiting from their involvement in those planning grants. The certification would allow them to get a better reimbursement rate, but our healthcare system is already improved for that.
Just not from the rate.
Yes, just
Yeah.
not for the rate, but we're
Okay.
already, getting the
So a lot of
benefit
process
this.
improvement stuff was able to be
That's
done
right.
by the planning grant, which then is embedded and not dependent on that.
Right,
That's right. They're two separate.
Yeah.
which is I won't say a great advocacy tool, but it is. So Texas, right? I think Texas is a state that for a long time didn't have the certification, but all of their providers pursued CCBHC status and stuff and went on to use that as an advocacy tool. Don't quote me on the state, but I think it was Texas.
Texas, Kansas, was legislatively required to move to a CCBHC
Yeah.
model. As of 2 years ago, we've kept our eyes on both of those. Those are also not Medicaid expansion states. And so one of the things that we really had to look at is what is the difference between a state that hasn't done Medicaid expansion and a state like Vermont that does have Medicaid expansion and how that impacts the CCBHC model. And so we've been in close communication with, with other states around that as well. And the National Council and their expertise, they are also very deep into this with almost every state in the nation. It's a higher quality of care and a higher reimbursement, which in in the end helps us achieve those goals of getting folks services when and where they want it.
Can I make one last comment? And then we'll go there. Just to commend DMH and especially Emily and Allison's leadership, because I think you jumped on this opportunity and have taken it so far. It's just incredibly impressive. Like Lori mentioned, that I'd worked with a lot of other states on this initiative, and I'm really, really proud that Vermont has taken it this far, and also with Simone's leadership of the DAs. It's just really nice to see that we're gonna do this for Vermont, and that we're trying, and that agencies are pursuing it on their own, and that the state's backing them up. It's very promising. Thank you.
Thank you.
Art?
Yeah, it's funny you swore in the Medicaid because I was gonna. My question really is, and in the past couple of days, we've heard about stuff that's only for folks with Medicaid. What about this? This for everyone? Or is this strictly targeted toward those on Medicaid?
It is Medicaid reimbursement focused, Medicaid eligibility focused.
Okay, so someone who is struggling with opioid, but has a good job, that is on Medicaid, has on private insurance, can he get this also by coming to these facilities?
Yes, the services, it would just be billed a different way to the
Oh,
insurance provider.
Okay, it would be billed a different way, but the services provided would, from CCBHC, would be the same. Okay, so you do serve non-Medicaid.
And our VA system does now too. They serve folks with private insurance now as it is.
Right, that's what I
Yeah.
thought.
Yep.
But I just want to make sure, okay. And, the folks have skin in the game. Do they have a copay? Do they have, what do they have? Anything?
There aren't copays with Medicaid, but there are some copays with
Sure.
with private insurance.
And so depending on your policy.
Depending on your situation.
It isn't different for a drug addiction thing. It isn't different.
Tell me what you mean by that.
If you're going in to get clean.
Okay, so this is gonna be an
It's treated
outpatient.
differently.
I got you. So the CCBHC model is an outpatient model. So what could happen is, let's say somebody needs and is medically necessary, or it's medically necessary for them to be in an inpatient facility or a residential facility for their substance use. CCBHC would coordinate their return back to the community and deliver those services
But the residential treatment or the recovery center would be through
outside of this model.
outside of this model, and it just depends on what your insurance is, if it's covered or not.
Right, but you still have outpatient treatment for it.
Outpatient treatment, yep.
Yeah,
Outpatient treatment is typically, let's from the substance use world, less than 10 hours a week of treatment. And that's done in an office-based setting versus in a facility. That's going to be your outpatient.
and they may or may
and
not have a copay for that.
They may or may not, depending. on the
Okay,
situation.
depending on the plan.
Yeah.
Okay, thank you.
Yeah, you're welcome.
Okay, any other questions?
Thank you for coming back. We are gonna keep our fingers crossed that we get selected, and we'll wait to hear.
Yes, thank you.
Thank you, Bob.
Thank you.
So this is quick. Who is this through? Which department that you did submit your application to?
SAMHSA,
It is SAMHSA.
yes.
So it's totally unrelated to our value-based application. That's a whole other
Yeah,
land.
that's a whole different,
Yeah.
yeah.
That's right.
Yes.
Still,
The guy that got his hair cut, oh, that's Samson. Oh, boy. Different thing.